My name is Andy Hunsaker and I'm from Boston, and I will be speaking to you this afternoon on pitfalls in CT pulmonary angiogram imaging. Obviously, CT pulmonary angiography for evaluation of pulmonary embolism has caught on dramatically simply because it is a very sensitive and specific test with sensitivity of up to 94 to 96% and a specificity of 94 to 100%. Treatment decisions are based on the renderings of what we as radiologists give to our referring clinicians. If we say the test is positive, the patient is placed on anticoagulants or an IVC filter is placed. If it's negative, then no treatment is rendered and an alternate diagnosis is given. However, if we say that the test is indeterminate, different things can happen. Some of our referring base will just assume it's negative, but others will proceed with something else. I have 5 images here for you, all different patients. Obviously, what you'd like to see is a good quality study as the one is listed above. One is negative and the others are obviously positive. However, when you have an indeterminate study, that is somewhat problematic. And so what do we do with those particular studies? In a meta-analysis looking at 16 studies of inconclusive or indeterminate studies, CT studies, 327 patients were evaluated with those particular attributes. Of those patients, 74 patients were evaluated. They were not placed on anticoagulant therapy, but they underwent further diagnostic workup. And in those patients, 16.4% of them were found to have some form of venous thromboembolic disease, which underscores the need for follow-up of all indeterminate studies and to specifically find out why the study is indeterminate. This afternoon, our objectives are several. We'll look at, first of all, indeterminate studies, and those can be due to technical, physiologic, or anatomic reasons, but there are other pitfalls in CT pulmonary angiogram imaging, one of those being an error in diagnosis, and the other is an error in tunnel vision. And those are some of the most interesting and some of the most costly to the patient. We'll also look at dual energy CT and offer solutions to these pitfalls. By way of introduction of our topic and launching into it, I want to present you a case. We will not look at the answer right now, but at the end we'll come back to this particular case. This is a real patient that came to our institution. She was 23 years old, presented with symptoms consistent or at least suspicious for acute pulmonary embolism. She had a poor quality study, as you see here. She was scanned with 75 milliliters of a high iodine contrast material, and 140 kVp was used. What would you recommend next to the referring clinicians? A, either repeat the study with increased volume of contrast, an MRA, or repeat the study with increased KV or another study. Just think about that, and at the end we'll come back and we'll get a show of hands as to what you would do. Inherent in the CT scanning protocol are reasons for indeterminism. And as you can imagine, when we ask the patient to take a deep breath in, obviously there are some physiologic things that can take place, and that was one of the things that we mentioned for indeterminism. Also, the scan delay is usually set at about 20 seconds, and bolus triggering can help with some of those issues. Also, the volume of contrast material, the selection of KV, and other patient characteristics. Those can all lead to indeterminism. So first we'll look at the technical pitfalls, the most common being motion and breathing artifact. There are others that can lend itself to technical pitfalls, including technological errors such as improper selection of imaging parameters and placing the cursor improperly on the triggering scan. The most common being respiratory motion artifact. This can lead to an apparent termination of the vessels, and it can also lead to a variation in pulmonary blood flow between inspiration and expiration, causing heterogeneous opacification. If you look at the lung windows, those can be helpful. This was a case of a young man when I was on call one weekend who presented with a herniated left lung, but because he was short of breath, and because all shortness of breath seems to require a CT pulmonary angiogram, one was obtained. And I've circled the abnormality that caught my attention. But if you look here on the lung windows, there's obviously respiratory motion. The patient actually died about 2 days later, and the autopsy showed no evidence of pulmonary embolism nor of pulmonary infarction. So that was simply motion artifact. There's another pitfall which you may or may not have seen, and that is these linear opacities, and mostly residents fall into that particular pitfall, and that's actually an error of the scanner itself, the detector rotation. If you do not use a gated study, then the detector is a full gantry rotation, and that can lead to this artifact. And that can be corrected by gating the study, because that is a half gantry rotation. And the slower speed, you have a better spatial resolution and less temporal resolution, and that will cure that particular artifact. Now we'll look at physiologic pitfalls, and they fall into about 3 categories: abnormality of venous inflow, transient interruption of contrast or tic is the first one, or SVC obstruction. Then, of course, you can have extrapulmonary shunts, typically a right to left shunt. And then there are other intrapulmonary shunts. And first, then, we'll take a look at transient interruption of contrast. It's more common in pregnant patients, and it is a normal response to a deep inspiratory effort, resulting in a negative intrathoracic pressure, which causes inflow of unopacified blood into the IVC and the SVC. The amount of flow depends on the end diastolic filling pressures, with the least amount of flow with a high end diastolic pressure. And here we see again what that looks like. The clue to the abnormality is a lack of opacification of multiple vessels at the same level bilaterally without vascular expansion. And then you see unopacified blood in the right heart, followed by unopacified blood in the left heart and the aorta. Here is the exact same patient that we imaged again, and the thing that will help with this is just hyperventilating the patient prior to the study, which reduces the accumulation of unopacified blood in the IVC. And also, if you delay the initial image acquisition by at least 5 seconds after inspiration, that will help the tic to pass as well. The scanner obviously will not help with that. Now, in a very interesting study on 327 patients, they found that the tic was more common in patients who had negative PE than those that has a positive PE. And that's because in patients with a positive PE, the end diastolic filling pressure is increased, and which leads to a decrease in right ventricular output, and that attenuates or prevents the inflow of unopacified blood. Now we'll move on to right to left shunts. About 25 to 30% of all people have an insignificant PFO at rest, and most have no symptoms, but under certain conditions, a transient opening of the PFO can result in a right to left shunt, and that happens if the right atrial pressures exceed the left atrial pressures. And this can occur during Valsalva, or deep inspiration, or coughing. Now what you see is a significant and early enhancement in the aorta, with the aorta having attenuation value is much higher than the pulmonary artery. The reason for this is the same as for a tic, is a deep inspiration, deep inspiratory effort, and Valsalva, which causes a sudden increase in the right atrial pressure. Power injection can also cause this to occur. And here's an example of this sort of a situation where you have increased opacification within the aorta, the left atrium, and the pulmonary veins. And all you do then is have the patient breathe in quiet respiration, and that will alleviate that particular pitfall. Now, if you scan a patient who has a known PFO, it's very important to take certain precautions, because those patients can obviously have a paradoxic pulmonary embolism. So always use a new IV, and a longer scan delay will be also important, as well as performing the examination either silent respiration or near the end of expiration. And beware of free-floating right atrial emboli. There's a patient that we had at our institution who, it was unknown to us that the patient had a PFO. The patient was scanned and found to have pulmonary emboli, obviously as you see here, and also had thrombus in the aorta. So very important if you can ascertain whether the patient has a right to left shunt. Anatomic pitfalls can occur anywhere along the arterial tree, including segmental and central vasculature. Along the segmental artery, it's very important to remember that anything tubular can mimic a filling defect within the pulmonary artery. That will include bronchi and pulmonary veins. Here's an example which is a very obvious one, I think quite easy to pick up, but still can be a pitfall for particularly a resident maybe, or for someone who does not look at these studies very often. This is a case of mucoid impaction. You can see the filling defect here within the bronchus intermedius and within the other segmental pulmonary arteries. Remember that the bronchi run with the arteries, and here the patient is with an opacity also in the right lower lobe. There's actually a patient with pneumonia and mucoid impaction. Now this one was a little bit more difficult for us. Certainly this looks very much like pulmonary embolism with branching filling defects. What we did in this particular case is did a MIP study, and certainly these are pulmonary arteries which are perfectly normal. However, the accompanying tubular branching structures turn out to be bronchi with mucoid impaction. You can see the gas within the airways. And so this was just simply mucoid impaction in a patient with a central bronchogenic carcinoma. Remember that you don't only have nodes in the hilum, but also you have bronchial nodes. So very important to note that those will not be necessarily filling defects, just trace them back. And you can see that they run along in a fashion consistent with nodes. And this was a patient with nodes. This brings us to a portion of the presentation which I particularly like, because I tend to fall into some of these pitfalls myself. And you'll see some of my gaffes in a moment. But these include mimicas of PE, which include things like tuba thrombi or emboli, pulmonary artery sarcomas, missed carcinomas, or intracardiac masses. Here is a patient who presented with symptoms again, and all these patients present with shortness of breath, so it's difficult to tell what exactly is going on. This patient was unknown to our institution and did not have any known diagnosis, but presented with symptoms. For some reason, we felt that there was some quirk in this particular study, and we thought, well, maybe this could be a tumor. So we actually rescued ourselves from this particular pitfall. The patient had a VQ scan which showed no perfusion in the right lung whatsoever, which didn't help, but the patient then had a PET CT, which showed indeed that this was a very FDG avid lesion, and this patient indeed had a tumor thrombus secondary to a bronchogenic carcinoma in the right hilum extending into the arteries. Tumor emboli can present as large filling defects and present very much as an acute pulmonary embolism. They can produce acute pulmonary artery hypertension due to the vessel occlusion, but more commonly they occur in small vessels and include the subsegmental arteries, leading to progressive dyspnea and subacute pulmonary hypertension. There's a patient who we actually read as having a pulmonary embolism, but the patient had a known cervical carcinoma, and so she underwent a PET CT study for evaluation of metastatic disease, and interestingly, this filling defect actually lit up on PET CT, and this was actually a tumor embolism from the patient's cervical carcinoma. They're often associated with organizing thrombi. Prostate and breast carcinoma are the most common causes of microemboli, followed by hepatoma and carcinoma of the stomach and pancreas, but any tumor can cause a microembolism. As I mentioned, they can be large filling defects in the main, lobar, and segmental pulmonary arteries. They could be subsegmental, but one thing I want you to note is they can be also within the secondary pulmonary lobule in the arterioles, and they can have a tree and bud appearance. So if the patient does not seem to you by history to have a bronchial reason for the tree and bud abnormalities, think, could this be arterial? This is a patient who presented again with symptoms, and this was quite obvious to us that this was not likely to be a bland thrombus because of the cauliflower appearance of this lesion, and so we accurately call this one to be a thrombus due to a tumor or a sarcoma, and it turned out to be a pleomorphic rhabdomyosarcoma. Here's a patient who presented also with symptoms, and they all have the same symptoms. Very difficult to differentiate them based on their symptoms. But this patient presented also with a large filling defect in this left main pulmonary artery, extending into the segmental and subsegmental pulmonary arteries. That was the location, but if you notice on this particular coronal image, there's some enhancement within this abnormality, and this was all one clue that maybe something was up. We did an MR to help us out with this particular lesion, and not that it was particularly necessary. I would not necessarily say that you need to do this, but it just showed some neovascularity. We did this also with intravenous contrast material showing this tumor thrombus, and this was indeed all thrombus in this patient also with a sarcoma. The patient presented 2 months later. These tend to extend outside of the pulmonary artery, and so you can make that diagnosis based on the extension outside of the vessel, something that PE tends not to do. Pulmonary artery sarcomas are uncommon causes of intraluminal arterial defects, although at my institution they seem to come in every month or so. They tend to be unilateral and lobulated and heterogeneously enhanced. They expand the pulmonary artery and show extravascular extension. They may have subpleural nodules or consolidation or pleural effusion. And I'm just showing you these two together. Some have said that the pulmonary embolism tend to be smoother and show no enhancement. This may or may not be so, but that's something that you can use. This is a patient who I fell into the pit on this one. This is my Waterloo, and quite an unfortunate patient. There's a pitfall of tunnel vision is what I would call it. Tunnel vision can happen in multiple ways, either by history or by just satisfaction of surge. This is a 27-year-old patient who was referred to our institution for an embolectomy. On the day prior to the patient's scheduled surgery for embolectomy, the cardiac surgeon came to me and said, I just need to get a roadmap of what I'm going to be seeing when I go to the operating room. And so we went through the study, and I showed him all the areas of thrombi and embolism in this particular patient, and it never occurred to me that there could be an alternate diagnosis. It turns out that the patient was admitted to another hospital prior to coming to our hospital. He was admitted to another hospital in 6 months prior with symptoms of shortness of breath, and was sort of not taken very seriously because of his age. He presented again in October, 6 months later, to that same institution where they performed a CT pulmonary angiogram and told him that he had a pulmonary embolism, chronic pulmonary embolism. Hence, he was transferred to our institution. He was taken to the operating room, and the next thing I knew was the next day when the cardiac surgeon came to me and said the patient almost died in the operating room. I said, well, what happened? The patient's central venous pressure went to 30 centimeters of water, and the patient became rather hypotensive. They found the heart to be quite black when they went in, and the patient literally almost died on the operating table. What happened? They sent the specimen for frozen section, and it was very friable and necrotic looking. Had I think, not been jaded or swayed by the particular history given me, I might have taken my time and done MIP images, which is what I did later, which showed there's some enhancement and some rather large bronchial collaterals, which can happen in a chronic pulmonary embolism. However, on these images, you can see the enhancement in this particular lesion. And it turned out that this patient had a high-grade myxoid spindle cell sarcoma. One of the things that was also disturbing about this particular case, it was bilateral. This patient was basically sent home to die. But I felt rather poor because being an experienced thoracic radiologist, to make such a mistake was quite humiliating. But again, I think these things can happen to anyone, and I think looking again at this patient, looking at the enhancement in the pulmonary artery is helpful. We move on to intracardiac abnormalities. I'm going to show you two cases. This one, which shows an abnormality in the right atrium. Here we see it here, in this particular patient. Here's the second patient, again with an abnormality in the right atrium. Are these real or not? In this particular one, there's also abnormality extending into the inferior vena cava. I'm going to put them side by side. Abnormality number 1, as I showed you first, and then the second abnormality extending into the inferior vena cava. One of these has an intracardiac thrombus, the other is just a mixing artifact. It's a little bit difficult to tell, and here we are with the mixing artifact in this particular patient on the top and a right atrial thrombus. Both of these were not mentioned on at the time of interpretation of this particular study, but for some reason the referring physicians felt that this patient did have something wrong. So an echo was obtained, and indeed in that second patient you can see the filling defect here in the right atrium, and then you can see it popping into the right ventricle and then into the inferior vena cava. So be very careful with looking at those artifacts. Sometimes they can be an artifact, but sometimes they can be a real filling defect in the heart. Misdiagnosis. This was a very sick patient that came in with symptoms again of pulmonary embolism. And of course, we searched for pulmonary embolism and did not find one. We were very happy to report, we know what's wrong with your patient. She has a combination of pneumonia and atelectasis. And that's how the study was read out. The patient returned 3 months later with this particular lesion. Well, this was actually on the previous pulmonary angiogram study, and where in the world was it? If you notice, there's actually heterogeneous enhancement in this particular lobe. You can see the abnormality here. I'll fill it in for you with this nice fuchsia color, and this is it here. And so be really aware of other abnormalities that could be missed, particularly with consolidation in these sometimes very confusing cases where a lot is going on. There's a wonderful patient where I redeemed myself. There's a patient who had a right upper lobe wedge resection for an early stage lung cancer. Returned to the thoracic surgeons for a routine follow-up, but had symptoms of hemoptysis. The thoracic surgeon came in and just wondered what was going on, and I said, well, I'm quite convinced because the patient was not immunocompromised. I did not consider mucor, and she did not travel, so I didn't consider paragonomyosis. But I thought this could certainly be an infarct with a reverse halo sign, etc. He did not actually believe me, but I convinced him to do a CT pulmonary angiogram, which he did, showing a filling defect here extending into this area of an infarct. So remember that sometimes you can work backwards and get to a diagnosis of PE. There's another patient who was referred to us also from an outside institution who had also came with shortness of breath and was noted to have these abnormalities and this filling defect here in the pulmonary artery. The patient was bounced from hospital to hospital and came to our hospital, and multiple biopsies were performed of this particular lesion, and nothing came back but just inflammatory material and some debris and some macrophages. Because there was a tunnel vision for bronchogenic carcinoma, the thought of an infarct and pulmonary embolism was never entertained until finally someone or a section suggested that could this be an infarct, and indeed it was. This was infected pulmonary embolism, and this was an infarct, and the patient received treatment. Now we'll finish up with artifacts due to dual energy CT. Non-embolic perfusion defects can be seen in patients without PE, particularly in the apical and anterior segments in the right upper lobe and apical portion of the left upper lobe, and also in the right middle lobe along the heart and the diaphragm. These are typically due to either motion artifact or beam hardening due to the high contrast density within the brachiocephalic vessels, superior vena cava, and the right heart. You typically see a band-like or crescent shape, not a wedge-shaped abnormality. This can be minimized with saline chaser and craniocaudate direction of scan. This is from radiographics. And iodine perfusion maps are performed in maximum parenchymal enhancement. And if you have an aberrant vessel, then that, because it's not maximum perfusion, can show a filling defect, a perfusion defect there, which this says, but this is not actual. This is just because of slow flow. If you have a non-occlusive pulmonary embolism, you can have a false negative perfusion map. And of course, you see the crescentic abnormality along the heart and the diaphragm from cardiac and diaphragmatic motion. Now we're back to our case. And I know it's a little bit difficult to see in here, but how many, if you've had thought about this case, how many of you thought that number A would be a reasonable suggestion on this 450-pound woman with this poor quality study? How many thought a repeat study would be a good thing to do? Just show your hands. How about an MRA? How about a repeat study with increasing the KVP? How about lowering the KVP? How about another study? Good. So we suggested the patient just have a simple VQ scan, which is completely bound or normal. And if the chest X-ray is normal and you have difficulty with a PECT study, just do a VQ scan. Those are excellent studies, and the patient survived that and did very well. So in conclusion, we've identified reasons for indeterminate studies. It's very important to sort of pass these out, because what you do with the study, either by follow-up or repeating the study, will be different based on the reason for the indeterminism. Always consider other etiologies for filling defects that can mimic a bland emboli. Sometimes the given history of PE can be a distractor to other potential diagnoses, and so it's very important to, at one point, exclude the history and really look at all the images carefully, and always consider alternative studies. Thank you very much for your attention. At this time, I'd like to welcome Dr. Diana Litmanovich, also from Boston, just down the street from me. She'll be speaking to you on pulmonary embolism.
Good afternoon, and thank you for joining the Afternoon Essentials in Chest Imaging series. I'm going to talk about imaging of pulmonary edema, the heart and lung interaction. And although I don't have any financial disclosures, I do have one important disclosure to make, that this talk was inspired and supported by the work of Dr. Eric Milne, devoted to pulmonary edema. In the next 30 minutes, I would like to outline the main causes of pulmonary edema, to discuss the radiologic features that are specific to different types of pulmonary edema, as well as discuss the clinical relevance of those findings. What is edema? It comes from ancient Greek, and it means pathology of excessive accumulation of serum in tissue spaces or body cavity. Starling equation describes the balance of hydrostatic and oncotic forces within the pulmonary capillaries, and it focuses on the Q, the net movement of fluid across the endothelium, where the hydrostatic pressure P favors the movement of fluid from the capillaries to the interstitium, and the oncotic pressure pi favors exactly the opposite. The causes of pulmonary edema can be divided into two main categories, one being the hydrostatic pulmonary edema that can be subsequently subdivided into cardiogenic and overhydration, and into increase in capillary permeability due to lung injury. This diagram summarizes the known and very commonly used findings that are used for detection of pulmonary edema, determination the type of the pulmonary edema, and the assessment of the severity. And they are the size of the heart, the size of the vascular pedicle and azygos vein, presence of interstitial and or alveolar abnormalities, as well as pleural fluid. Let's start with the redistribution of blood flow. Normal or balanced redistribution of blood flow is very difficult to determine, but inverted blood flow with the main part of the blood flow going to the upper zones of the lungs can be determined on regular radiographs, even when it's very subtle, like in this case, or more pronounced with substantial increase in the upper zone blood vessel diameter and surrounding interstitial changes. Pulmonary blood flow is the next parameter to talk about. Pulmonary edema is very rare, comes with decreased or normal blood volume, but the increased blood volume can be seen, and it actually corresponds to pulmonary vessels that are extending toward the very periphery of the lungs. Cardiomegaly is considered to be present on the chest radiograph, where the cardiac diameter exceeds half of the diameter of the chest in patients where the chest radiograph was obtained in upright NPA projection. For the supine or AP radiographs, the ratio will be 0.6. Although this sign we all know is very non-sensitive and non-specific, it's useful for initial assessment of chest radiograph for detection of pulmonary edema. The vascular pedicle size is the width of the mediastinum at the level of the aortic arch and SVC. And this size is actually an indicator of the circulating blood volume. It usually should not exceed 55 millimeters. But if it's distended beyond 68 to 70 millimeters, it's definitely abnormal. It's important to remember that there is a direct correlation between the width of the vascular pedicle and the height and weight of the patient. It also slightly increases in supine position, but it's also important to remember that the absolute number has a relatively limited relevance. What is important really is the sequential changes in size of the vascular pedicle in the same patient over time that are actually reflecting the change in the blood volume. Peribronchial coughing is another very known but probably underutilized sign of pulmonary edema. In normal situation, we can barely see the wall of the airway, but it can be easily seen when there is a bronchial wall thickening, which is actually the filling of the peribronchial vascular sheath with fluid. And the peribronchial vascular sheath is not the only one which is affected, but also the sheath surrounding the vessels. Thickened interlobal septa anatomy is clearly depicted on CT. And this hexagonal smooth thickening of the secondary lobule wall is a hallmark of interstitial pulmonary edema. What we also can see on the CT is the thickening of the bronchial wall and the ratio between the dilated vessel and the corresponding airway. The very well-known curly lines are actually the projection of the multiple thickened interlobal septa that we just saw on the CT image on the 2D image. The curly B lines are running in horizontal plane. They are running at the periphery and the lower aspect of the lungs, and they're usually associated with fissure thickening. In contrary, curly A lines, which are much more difficult to see and that are seen on the chest radiographs not that frequently, are longer, they're running in an oblique fashion, and they're usually seen in more central portion of the lungs. Alveolar opacities is the next finding seen in pulmonary edema. It's usually in the mid and lower lungs, and also presented as ground glass opacity on the chest CT, which is actually representing fluid within the alveoli. The ground glass opacities usually follow the gravity gradient, and they are more pronounced in the posterior aspect of the patient who is in supine position and the lower aspect of the lungs in patient who is upright. They also can be asymmetric, like in patient with mitral regurgitation, where due to the reflux of the blood through the mitral valve into the right upper pulmonary vein, the opacity will involve in asymmetric fashion the right upper lobe. It can be seen in up to 10% of adults and much more frequent in children. When the alveolar consolidations are caused by the lung injury edema, the gradient is much more pronounced. We see that the consolidations are much denser at the posterior aspects of the lungs. There is also a very frequent presence of air bronchogram because the fluid within the alveoli is of high protein content that gives us the air bronchogram similar to pneumonia. So let's talk about the radiographic presentation of different types of pulmonary edema. To differentiate them, we should think about the pattern of distribution within the lung, the increase or normal pulmonary blood volume, the size of the heart, but what even more important is the timing, in the sense of the correlation in time between clinical and radiological findings, between the rapid versus slow development of pulmonary edema and rapid versus slow clearing of pulmonary edema. Let's start with cardiogenic pulmonary edema, and let's go to the basic physiology. So the increase in the left atrial pressure increases the pressure backwards, translating it to the increase in the venous pressure and then subsequently increase in the capillary pressure. After rapid increase in capillary hydrostatic pressure, pulmonary edema develops. But between this increase and the development of pulmonary edema, there are other changes that happen. As a response to the increase in the transcapillary gradient, there is capillary recruitment and distension in an attempt to compensate for this increase in the gradient. And when this recruitment and distension are exhausted, then the movement of fluid into interstitium starts, with interstitial and subsequently alveolar edema developing. The pressure in the left atrium and pulmonary arteries can be measured with the Swan-Ganz catheter using the pulmonary capillary wedge pressure assessment. This is done by inflating a balloon in a distal branch of the pulmonary artery, and measurements distal to the inflated balloon are taken corresponding to the left atrium and pulmonary venous pressure. It's important to mention that in acute heart failure, there is a time lag between the actual increase in the pulmonary capillary wedge pressure and the radiological manifestations that we can see on chest radiograph or CT. The pulmonary capillary wedge pressure corresponds very well to the severity of the pulmonary edema. Thus, in the beginning, with only vascular distribution present, the pulmonary capillary wedge pressure is at the range between 13 and 18 millimeters, and when alveolar edema is already present, it exceeds 25 millimeter mercury. What happens in the early stages is a central leakage of the fluid into the interstitium, with the cuffing, the bronchial wall cuffing that we were talking about. At the later stages, the periphery is involved with the curly line and subpleural fluid accumulation. As edema progresses, there is leakage of fluid into alveoli corresponding to the increased pulmonary capillary wedge pressure. So when we look at the chest radiograph, we see central and peripheral edema with the gravitational distribution, presence of cardiomegaly in a substantial amount of cases, as well as flow redistribution. But we should remember that in acute cases, there is normal vascular pedicle size and normal azygos vein because the actual circulating blood flow is not increased. Let's look at this case that summarizes those findings with central and peripheral edema present, with gravitational distribution of the apacities, cardiomegaly, and upper zone flow redistribution. We should remember that vascular and mild interstitial changes might actually precede substantial clinical findings, like in this case of a patient who presented with mild chest pain. We can see barely a little bit of the upper zone redistribution that substantially progressed in 24 hours to frank pulmonary edema. So we should be very cautious when interpreting those studies because this is our opportunity to alert clinicians about the potential changes that are brewing. We also should remember that the progression between the vascular to interstitial or interstitial to alveolar finding can be very rapid at the level of the interstitial as well as at the level of the alveolar changes. Vascular, interstitial, and alveolar findings, all of them, on the other hand, can rapidly improve in response to intervention. The clearance of the cardiogenic pulmonary edema occurs along those four channels: change in the pressure gradient, lymphatic system, passage of the fluid into alveoli with subsequent clearance, and the fluid drainage to visceral pleura. The most important one in cardiogenic pulmonary edema is the reversal of the pressure gradient, where we don't have this hydrostatic pressure pushing out the fluid from the vessels. So in this case, we have decrease in the intracapillary hydrostatic pressure, but we also have increase in the intracapillary oncotic pressure, since a substantial amount of fluid have already leaked out from the capillaries, thus the oncotic pressure inside is high, and the combination pushes the fluid inside of the capillaries. The lymphatic system is very important, especially in chronic pulmonary edema, and the drainage occurs toward the mediastinal lymph nodes as well as through the lymphatics to the lymphatic duct with subsequent drainage to the venous system. Fluid from the interstitium can go into the alveoli and then it drains again through the lymphatic system by ciliary movement and by cuffing. It is very interesting that the fluid drainage to visceral pleura is very often underdiagnosed or not taken into account, but it actually plays an important role in drainage of pulmonary edema. It goes to the pleural space and then through the lymphatics to the venous system. But what is also important to remember that here we also have lagging after the alveolar clearance. Let's look at this case where patient arrives on the first day with mild interstitial changes, progresses to frank interstitial pulmonary edema, and on both those studies we don't really see pleural effusion. After his edema cleared up, we start to see pleural effusion, which actually represents the clearance of pulmonary edema. In chronic cardiogenic pulmonary edema, we're usually dealing with increased circulating blood volume, thus the large vascular pedicle and azygos vein can be seen, and there is upper lobe blood flow redistribution and very frequently cardiomegaly due to the chronic nature of the problem. This is an example of a patient with increased vascular pedicle and azygos vein. He has cardiomegaly and redistribution of the pulmonary blood flow. This is another example where we can see that the redistribution, which is potentially chronic situation the patient arrives, has progressed to interstitial pulmonary edema. The other important, although rare, cause of chronic cardiac pulmonary edema is veno-occlusive disease, where there is narrowing or occlusion of small pulmonary veins or venules by organized thrombi. That progresses in two directions, causing pulmonary hypertension on the pulmonary arterial end, and also increases the hydrostatic pressure within the venules, causing pulmonary edema. What is interesting that since the large veins are not involved, the pulmonary capillary wedge pressure would be normal. In addition to usual septal thickening that we see on the chest CT, there are centrilobular nodules seen which actually represent the dilated venules. Let's talk now about the other type or other cause of pulmonary edema, which is overhydration pulmonary edema. There is definitely certain overlap with cardiogenic pulmonary edema, but the main feature is, and the main cause is, actual increase in the total blood volume. We will see wide vascular pedicle and azygos vein. We will see balanced redistribution of the flow, cardiomegaly, and the changes are actually similar to chronic cardiogenic pulmonary edema. Let's look at this case, which is indeed very similar to chronic cardiogenic pulmonary edema, with wide vascular pedicle and azygos vein, dilated, balanced redistribution, and cardiomegaly. In overhydration pulmonary edema, really the distinction between cardiac and renal edema very difficult to make. And it's much easier to distinguish from lung injury pulmonary edema. The dilated vascular pedicle and the azygos vein with no pulmonary edema can be seen, but they're usually happening in iatrogenic volume overload in the presence of the normal cardiac function and the normal renal function, or in pregnancy. Let's talk about hyperacute pulmonary edema. The appearance is similar to cardiac and overhydration causes, and the interstitial phase may be absent when we look at the chest radiograph. Central distribution is a key, so-called bat wing edema, and there is sparing of peripheral interstitium, with central interstitium sometimes seen and sometimes not present. Let's look at this case where we see the radiological appearance of the central involvement of the lung by the pulmonary edema and real sparing of the periphery of the lungs, giving this bat wing edema appearance. It also can be seen on the CT with similar distribution as compared to the chest radiograph. Hyperacute pulmonary edema is associated with acute renal or cardiac decompensation, and clearing can be either symmetric or asymmetric, sometimes giving the chest radiograph or chest CT a very weird appearance. The clearing is usually also abrupt when the reason of acute pulmonary edema ceased or eliminated, but also can be delayed depending on the cause. The last type of pulmonary edema is lung injury pulmonary edema, where eventually inflammation causes the vascular endothelial damage and alveolar epithelial damage. And then the fluid leaks easily out from the vasculature and leaks easily into the alveoli, causing eventually pulmonary edema. Usually, the endothelial stent junction damage or the actual pathology precedes the radiographic changes for at least 24 hours. And then we can see mixed alveolar or interstitial form, random multifocal distribution, but what is important that if there is no overlying cause, the normal vascular pedicle and the normal heart size will be present, since the problem is not in the heart. There is absent or very small pleural effusion, and air bronchogram, again, is very often seen due to the high protein concentration of the fluid within the alveoli. There is also decrease in the overall lung volume due to the decrease in the lower lobe volume due to the atelectasis of the damaged alveoli. Let's look at as an example of the lung injury pulmonary edema, where we see this random peripheral multifocal distribution of the apacities. The heart is normal in size, the vascular pedicle is normal, there are no pleural effusions seen, and the air bronchogram is often demonstrated, like in this case. Again, there is very good correlation between the chest radiograph and chest CT appearance of those multifocal distribution parenchymal consolidations, the normal heart size, minimal or absent pleural effusions, and presence of the air bronchogram. This ventral dorsal gravity gradient is very often seen, and we can see how the density of the lung consolidation increases toward the periphery according to the gravitation. We can see those air bronchograms, and we know that the density of the lung parenchyma posteriorly can be changed by changing patient position. This gives this mosaic appearance to the lung, where the superior portions are very spared, followed by the ground glass opacities and frank dense consolidations toward the periphery of the lung. The peak of the lung injury pulmonary edema usually at the 24 to 36 hours after injury, but it can be unchanged for days, and the resolution is very slow from periphery of the consolidation inward, like in this case where we can see large basal consolidation with air bronchogram slowly clearing again from the periphery inward. So the lung injury pulmonary edema should be suspected in cases of florid pulmonary edema with a normal vascular pedicle and normal heart size. We should also suspect it in cases of long-standing, slowly changing pulmonary edema with posterior dense consolidation seen in supine patients due to lung atelectasis caused by alveolar damage. Clearance is usually from the periphery inwards. Now let's go through several clinical cases. And we'll start with a patient who came through our chest reading room last week, and his first radiograph was obtained because he had very nonspecific chest pain. He rapidly progressed to pulmonary edema, as you can see on the second radiograph on your right, where we can see dilated pedicle, increased heart size, redistribution of the blood flow, and interstitial changes. As part of his assessment, CT angiography of the chest was undertaken since the suspicion was for aortic dissection. But what we do see here is a large perfusion defect of his left ventricle that involves septum, the anterior wall, and also the apex. Echocardiography was obtained and actually showed substantial decrease in the ejection fraction as well as focal decrease in the movement, hypokinesis actually, of the anterior wall and the apex. The patient was taken to the catheterization that showed a total occlusion of the previously placed stent. So what do we have in this case? We have cardiomegaly, rapid progression of the findings with upper zone redistribution, wide vascular pedicle, perihilar, mid and lower lung distribution of pulmonary edema, and interstitial and alveolar changes in conjunction with acute coronary occlusion with corresponding left ventricular contractility changes. So we're talking about acute myocardial infarction-induced pulmonary edema. The next case is a patient who is 68-year-old, and he has a history of recurrent pulmonary edema. His first radiograph demonstrated subtle opacity in the right lower lung that actually rapidly cleared up, but on the subsequent radiograph, we see very conspicuous opacity in his right upper lobe. The echocardiography that was undertaken has shown a bidirectional flow during diastole through the mitral valve. So those findings would be corresponding to the asymmetric right upper lobe distribution in patient who will have severe mitral regurgitation with subsequent pulmonary edema. The next case is a patient who is 56-year-old, and he was presented in septic shock. The chest radiograph and axial CT image that are displayed now were taken at presentation, but there were no radiological changes seen in 5 days. We see normal vascular pedicle, we see normal heart size, we see multifocal consolidations within the lungs and presence of the air bronchogram with some increase in the density of the consolidations toward the posterior aspect of the lung. In this case, the combination of those findings, as well as unchanged radiological appearance in 5 days, will favor lung injury pulmonary edema. The last case is a 48-year-old patient with shortness of breath. On his presentation, we saw normal vascular pedicle, normal heart size, and relatively central or bad-wind pulmonary edema with relatively spared periphery and lower lung zones. His echocardiography demonstrated substantial decrease in the ejection fraction and global hypokinesia of the left ventricle. The history that was taken again, or actually retaken, actually revealed history of abrupt termination of long-term large-dose steroids. The patient was afterwards placed on the dopamine and steroids, and in this case we can see substantial improvement of the ejection fraction. Not only that, but there was also rapid clearance of the pulmonary edema 48 hours after initiation of treatment. So if we go over the findings in this case, in a patient with normal heart size, normal vascular pedicle, central distribution of pulmonary edema in the presence of global LV dysfunction, and rapid change after steroid treatment and dopamine, we're talking about pulmonary edema, a rare case that is caused by the Addison crisis. So in summary, I would like to emphasize that pulmonary edema is a common and clinically important feature of cardiac, renal, and systemic diseases. The radiologic findings actually closely mirror the pathophysiology of the process, and the radiological detection prior to full clinical expression is of paramount clinical importance. Differentiation between hydrostatic and lung injury pulmonary edema is sometimes possible radiologically, but should be always taken in conjunction with clinical findings. Thank you very much. It's my great pleasure to present Dr. Sujal Desai, who is coming to us from London, UK.
Thank you very much. Thank you to the organizing committee for inviting me. So we've been in the vessels, we've been in the air spaces and interstitium. It's my job now to take you on a journey of the airways. So I think it's fair to say that diseases of the airways are particularly common. As I hope you'll see, diseases of the small airways are incredibly common, and we encounter diseases of these airways very frequently in our clinical practice. I suppose as radiologists, this second statement has to be in there. Imaging has an important role, but I think it is true when clinicians are investigating patients with either established or suspected airways diseases. And we have really seen a real revolution in terms of the imaging of these airways diseases, particularly first with the advent of high-resolution CT, and then more recently with multi-slice CT imaging. Now, those of you who've been to a number of the lung lectures, you will have probably become a bit sick about the description of the pulmonary lobule, or the secondary pulmonary lobule, as it's called. I have no idea what the primary lobule is, but here it is. This is the secondary pulmonary lobule. This is the original description by William Snow Miller in his MD thesis, and it's an exquisite drawing based on his very detailed dissections. What is the pulmonary lobule? Well, it is defined as the smaller unit of lung structure, which is surrounded by connective tissue septa. And there is a reason why I'm describing this, because the airway diseases are intrinsically linked to the structure of the pulmonary lobule. It has a roughly polygonal shape. It can measure up to 2.5 centimeters in diameter, and it comprises between 4 and 8 acini. Another aspect of the pulmonary lobule that we need to know about is that we can see it in disease states, as shown in this case, and shown in that wonderful lecture by Diana, just shown that when you thicken up the interlobular septa, either by lymphatic permeation or edema, you will see the structure of the pulmonary lobule. In normals, the septa are incredibly difficult to see, but occasionally you will see them, as you'll see in a second. But the normal interlobular septum only measures 100 micrometers, so you're generally not going to see the interlobular septum. And if you're going to see it, you'll see it in the subpleural lung. The artery is the dot, as you know, in the middle of the airway, but the airway itself is very difficult to see because the wall of the airway really isn't very thick. This is a very targeted section of the lung, and you can just see the makings of a pulmonary lobule here, with the dot in the middle representing the lobular artery, and the airway next to it, which you won't see in normals. This is also important to consider. Now, we know that the trachea is the largest single airway, and as we go down, there is a gradual tapering in the diameter of the airway, and that's important when it comes to diagnosis of airways diseases. The other important thing to consider is that although the trachea itself has the largest single cross-sectional area, if you add up all the smaller airways, actually you have a huge cross-sectional area, which the trachea cannot even compete with. And that has an importance when we consider diseases of the small airways. And in fact, the small airways were really put on the map by Jim Hogg. And it's this paper published in 1968, which is really a landmark paper, because what Jim Hogg and his colleagues did was actually put catheters down into the airways and determine the resistance at various points as you go down the airways. Now, the small airways are defined somewhat arbitrarily as those airways which have a diameter less than 2 millimeters. So effectively, we're talking about the airways beyond the terminal bronchiole. In normals, so in you and I, they contribute very little to normal resistance. And in fact, Jim Hogg called this the silent zone of the lungs. Why? Well, it's very important because you can get a lot of damage in the small airways before the patient will describe any symptoms, or indeed before there is any physiological abnormality. So they are a crucial area of the lungs, but you can get a lot of damage before there's going to be any detection. This is a schematic diagram of the airways, and the division between the large and the small airways is effectively about there. So this is between the cartilaginous and the non-cartilaginous airways. The small airways, or the airways that Jim Hogg was talking about, start at about this level. But here is what's important. The resolution of high-resolution CT actually cuts out at that point. And that's important when we consider the signs of small airways disease. The only way you're going to see signs of small airways disease is either whether there's a pathological process which renders those airways visible, or there are some indirect signs related to abnormalities in the airways. And we'll get to that when I talk about the small airways. Now, which are the airway diseases that we should be talking about? Which are the clinically important? Well, actually, when you consider the large airways, there's really only one clinically important disease, and I will focus on that, on bronchiectasis in the next part of this talk. Actually, when you consider the small airways, the list is far longer and actually quite a bit more interesting. However, let's just consider bronchiectasis. What is bronchiectasis? As in many things in chest medicine, and in fact in medicine in general, the pathological diagnosis is often where we start. And the pathologists call bronchiectasis as an abnormal permanent dilatation of the airways. Now, I put permanent in inverted commas. It often puzzles me to see how a pathologist can see something is permanent, because actually pathologists often don't get more than one chance. Either they have a biopsy or they have a post-mortem in front of them. So how do they know that something was permanent? Well, actually, radiology actually has borrowed from that definition, and actually we are in a better position to determine something that is permanent because we can do serial imaging. And when it comes to bronchiectasis, we do look for the abnormal but permanent dilatation of the airways. And you know the yardstick that we use, we compare it with the accompanying pulmonary artery. And we'll come to that in a second. Now, when it comes to chest radiography, often this is the first test that is performed by clinicians, and there are many advantages to the chest radiograph, but there are also significant disadvantages. Now, to an audience of radiologists, I don't need to list those, I've actually put them there. And here is it in sort of plain sight. Now, most of us would have no difficulty in saying that this is an abnormal chest X-ray. Clearly, there's diffuse abnormality, and with some experience, most of us would say this patient has very bad cystic bronchiectasis. But this is not the typical patient with bronchiectasis that we see in 2013. This is generally what we see. Now, you'd be hard pushed to make a confident diagnosis of bronchiectasis on either of those chest X-rays. The point being that in most patients, bronchiectasis tends to be relatively mild. Now, what about CT? Well, if you read the early literature on CT, actually CT really didn't do that well. However, that was before the era of high-resolution CT. So how good is high-resolution CT in making the diagnosis of bronchiectasis? Well, it depends on what study you use or what you put up against it. Now, this was a study published by Kang and colleagues from Nestor Muller's unit, and this was perhaps the first study that compared CT, or high-resolution CT, with the so-called gold standard of pathological diagnosis. But when you talk about pathological diagnosis, almost by definition, that we're talking about advanced disease, because why else would you resect a lung or a lobe in which there is bronchiectasis? Nevertheless, this was the first study which actually then identified the key signs that I'm going to describe now of bronchiectasis. The absence of tapering. Remember, when we talked about the anatomy of the airways, there is a gradual diminution in the luminal caliber of the airways. So any absence of that actually is abnormal. The presence of wall thickening is also a feature, but it's not a diagnostic feature. And the visibility of airways in the periphery of the lung is also a key finding in bronchiectasis. So, accepting that the chest radiograph is not very good, CT really now is the accepted gold standard for making a diagnosis of bronchiectasis. What are the signs that we look for on CT? Well, it depends on which airways we look at. Whether they are orientated vertical or perpendicular to the plane of the section, or whether we're looking at airways which are in the plane of the section. When we look at airways which are orientated perpendicular to the plane of the section, we look for the so-called signet ring sign. What is this? Well, it's the dilatation of the airway in relation to the accompanying pulmonary artery. Mother Nature has decided that the transverse diameter of the pulmonary artery and the internal lumen of the airway are a roughly similar diameter. So any change from that is abnormal. So in vertically oriented airways, in the upper lobes and in the lower lobes, we're looking for the so-called signet ring sign. Some airways, for example in the lingula or in the anterior segments of the upper lobes and also in the middle lobe, you will see the dilatation in the plane of the section. So without these signs, the evidence of the non-tapering, you really can't be making a diagnosis of bronchiectasis. There are a number of ancillary features. Now, and I stress the word ancillary. You must not make the diagnosis of bronchiectasis based on these signs, but they are often present in patients who have bronchiectasis. First thing you get is crowding of the airways. Around the bronchiectatic airways, there's quite a lot of inflammation, and with the inflammation, you get a certain amount of scarring, and you can see here, in these cylindrically dilated airways, you will see the crowding which occurs in patients with bronchiectasis. Hand in hand with that, you will also get significant volume loss. As you can see in this patient, the marked pulling back of the oblique fissure in the left lower lobe. Mosaicism, which we will come to when we talk about small airways disease, is almost invariably present. It may be subtle, but in every patient with bronchiectasis, if you look hard enough, you will see signs of small airways disease, and that is manifest as mosaicism. Plugging of airways also occurs, and that may be in the large airways, as shown in the middle lobe here, or in the smaller airways, manifesting as a tree in bud pattern, the plugging of the peripheral airways that occurs. And these are the additional ancillary signs. And again, I stress the word, you must not make the diagnosis of bronchiectasis on any of these 5 ancillary signs that I've just shown you. What are the causes of bronchiectasis? Well, it depends on which part of the world you work. In the Western world, this is particularly true in England, where I work, but I'm sure it's fairly similar in the United States, and it's certainly true throughout Europe. Cystic fibrosis, immunoglobulin deficiencies, and in about a third of patients, idiopathic. You will not find a cause, or the clinicians, when they look, they will not find a cause of bronchiectasis. These are perhaps the 3 commonest etiologies of bronchiectasis. There are, of course, others. Post-infection is the one that registrars or residents often come up with. And there are a list of other causes of bronchiectasis that are listed in the textbooks. Are we good at telling clinicians the cause of bronchiectasis? Well, actually, occasionally you might strike it lucky. If you see an area or a lobe of the lung where there is an isolated, abnormally dilated airway, you might suggest this patient may have had tuberculosis or another infection in the past. Sometimes if you see flitting areas of consolidation with central areas of bronchiectasis, as in this patient, you might suggest a diagnosis of allergic bronchopulmonary aspergillosis, and occasionally you will be able to make the diagnosis of cystic fibrosis. But on the whole, considering the many potential causes of bronchiectasis, based on CT findings alone, you will not be able to offer the clinician a potential cause for the bronchiectasis, and that's been shown in a variety of studies. You can have a stab at the severity of bronchiectasis because there is a kind of grading in terms of dilatation. Some airways will just be cylinders, and you might suggest that this is cylindrical bronchiectasis. And then as it gets more severe, you will see the so-called varicose type of bronchiectasis, where there is more significant dilatation. And then it starts to get into this kind of end-stage lung phase where you get really gross or cystic dilatation of the airways. And so it's worth maybe making a comment in your reports about the morphological types of bronchiectasis, because there is an implied degree of severity as you go down those grades. Now, when do we get the diagnosis of bronchiectasis wrong? And I think this is important because there will be times when you will say bronchiectasis in your report and the patient may not have bronchiectasis. But consider this. It is now the gold standard test. The moment you say bronchiectasis in your report, it is going to go into the patient's notes. And I guarantee it, from that day on, every symptom the patient gets will be attributed to that diagnosis of bronchiectasis. If the patient has cough and sputum production, it will be attributed to bronchiectasis. If the patient has hemoptysis, it will be attributed to bronchiectasis. And if you've got that diagnosis wrong, you would have done that clinician and that patient a disservice. So when do we get it wrong? Well, if you look at airways which are too central, you have a chance of getting it wrong because we know from various studies that the airway and the accompanying pulmonary artery, which is the yardstick that we use to determine whether or not there is bronchial dilatation, they don't always branch at the same time. And also, because of the obliquity of the section, you will get a spurious effect of bronchial dilatation if you're looking at very central airways. The airways that you need to look at, as I've already said, are the airways which are roughly orientated perpendicular to the plane of the section. Then, when you have dilatation, you can say with a reasonable degree of confidence that this patient has bronchiectasis. Be careful before you make a diagnosis of bronchiectasis in these very central airways. Where else do we get it wrong? Well, age is a contributing factor. We know, again, from a number of studies that as we all get older, our airways have a normal tendency to dilate. Do these patients have cough and sputum production? No, they don't. So the clinical picture, together with the age, is also particularly important, and this was shown in this study by Matsuoka and colleagues who compared a group of patients at different ages and showed that as patients get older, these patients are completely asymptomatic, but you get this dilatation of the airways, which is a normal part of aging. So be careful before you make this diagnosis of bronchiectasis in patients at the other extreme of age. Okay, so enough about bronchiectasis. Let's move now onto the small airways, which I've suggested may be a potentially more interesting and actually more common form of airways disease. You will have read in the literature that there are a number of terms associated with small airways disease, and these are just some of them listed on here. And there is a profusion of terms that have been used historically throughout the literature. And one of the problems is that because radiologists, pathologists, and clinicians don't always talk to each other, and certainly don't publish papers together. And the reason is that each then understands small airways disease in their own way. Now, I hope by the end of this section, I can simplify matters for you. And not myself, but actually my old boss at the Brompton, David Hansel, has gone some way to actually trying to clear the mist a little bit. Now, this is by no means a comprehensive classification of small airways diseases. It can't be. There's only two entities on there. However, these two entities are two clinically important types of small airways disease. And those of you who were in Phil Boyzel's excellent lecture this morning will have heard of these terms. These will account for 90 to 95% of small airways diseases that we will all encounter in clinical practice. So it's worth having these two terms in your mind: constrictive or obliterative bronchiolitis and exudative bronchiolitis. Why are these two terms important? Why is it useful to think about these? Well, they do have reasonably well-defined pathologies and also correlative radiologies. The first type is the so-called constrictive type, and as the name suggests, what happens is you get inflammation around the small airways, it's patchily distributed, and that inflammation then leads to fibrosis, and that causes an obstructive defect in the lungs. And it's shown here in this line drawing and in this pathological specimen, showing fibrosis around the airway causing constriction, and hence the term constriction or obliterative bronchiolitis fits very well. By contrast, in this other category of small airway disease, what you get is filling of the small airway with inflammation, and then inflammation around the wall of that airway. And that's shown here. You can see this material inside the airway, and then the inflammation around that small airway. And this is the so-called exudative form of small airway disease. Now, why is that useful? Well, I've said because those pathological entities actually have two respective radiological manifestations. Here is a patient with constrictive obliterative bronchiolitis, and that's characterized by the mosaic attenuation pattern. And you're not actually seeing the small airways here, you're actually seeing an indirect sign of small airways disease, and we'll come to that in a second. Here, by contrast, is the exudative form, and that's manifest by the so-called tree in bud pattern. You get the exudation and the filling of the small airway with inflammation around in the wall of that small airway. What are the causes of constrictive obliterative bronchiolitis? Well, it's a pattern. It's a radiological pattern. It's not a diagnosis. So when you say to a clinician, this patient has mosaicism, and I think it's due to constrictive OB, it's then up to the clinician to say, well, what are the possible causes of constrictive obliterative bronchiolitis? And there are many. Viral respiratory tract infections are perhaps one of the most common. You've all heard of McLeod's or Swyer-James syndrome. Well, that is a form of obliterative bronchiolitis related to an adenovirus infection in childhood. But there are many other possible causes. What does it look like? Well, you already know. This is the so-called mosaic attenuation pattern. It's the patchy areas of black and white lung. And that's all mosaic attenuation pattern means. Black and white lung, which sit side by side on your CT scan. What are the actual key features? Well, areas of decreased attenuation, by definition. If you look inside the areas of decreased attenuation, there's a reduction in the number and or caliber of pulmonary vessels. There may well be bronchial dilatation. And remember that there is no parenchymal distortion. Why is that important? Because that differentiates it, not in these examples, because it's very obvious, but in some subtle examples, that differentiates from emphysema. In emphysema, you get areas of decreased attenuation, but there is associated parenchymal distortion. That's not the case in patients who have obliterative bronchiolitis. There was a vogue a few years ago for doing expiratory scans, and sure enough, when there's very subtle mosaicism, an expiratory scan may serve to enhance this, but nowadays less and less expiratory scans are done. But nevertheless, it's a feature of small airways disease where you will get air trapping on the expiratory phase of your CT examination. So enough about constrictive obliterative bronchiolitis. What about the exudative form of the disease? I've shown you these line drawings and the pathological correlate of that. What are the causes of an exudative bronchiolitis? Well, 9 times out of 10, it's going to be due to an infection. And that could be due to tuberculosis, it could be due to non-tuberculous mycobacterial infections, or it could be due to another group of causes. Now, Phil Boisel in his lecture said this morning, there's a paper hot off the press published in Chest, which actually showed that about 75% of cases were due to infection, and the other 25 were due to aspiration. There are some other rare causes, so-called diffuse panbronchiolitis, initially described in Japan, but not restricted to that country, connective tissue diseases, and certain non-airway causes of a tree-in-bud pattern, but less of that at this time. This is the classical description, and I'm sure if you've been to other lectures on the chest, you will have seen endless pictures of a tree in bud shown on your right-hand side, and then the CT manifestation of that tree in bud pattern. Once you've seen a few cases, not that difficult to recognize, but it's manifest by these very exquisite branching capacities, which may be either V-shaped, Y-shaped, or in full bloom, as shown on this CT section. Just another example here. This is a patient with non-tuberculous mycobacterial infection showing on these targeted images further examples of an exudative bronchiolitis. Okay, now those are the two sort of principal categories of small airways disease. Now the airways do get affected by other pathological entities. We've talked about constrictive obliterative bronchiolitis, we've talked about exudative bronchiolitis, but there are other histopathological and clinical entities in which the airways will be involved. And the first of those, which I'm sure you will have heard of, is respiratory bronchiolitis. What is respiratory bronchiolitis? Well, if you smoke, I can guarantee you have got respiratory bronchiolitis, because to a greater or lesser degree, all smokers have this macrophage infiltration around the peripheral small airways. Those macrophages are very characteristic. They are so-called pigmented, our pathological colleagues will tell us. There may be mild fibrosis, but most importantly, patients with respiratory bronchiolitis, most patients will be entirely asymptomatic. In a small proportion of those patients, you will get the symptoms and signs of an interstitial lung disease, and it is in those patients that you then diagnose the entity of respiratory bronchiolitis interstitial lung disease. What does that look like on a CT scan? Well, you will see widespread ground glass opacification, but additionally you will see the features of small airways disease. In other words, you will see these occasional areas of decreased attenuation, which if you did an expiratory scan, they will air trap. You will see some thickening of interlobular septa, as highlighted by the yellow arrows. If you look hard enough, you will also see some emphysema. Now, the emphysema is rarely very extensive, but usually you will see some paraseptal emphysema in the upper zones, and that's the clue that what you're looking at may be smoking related, and perhaps you're looking at a respiratory bronchiolitis. So that's one cause of small airways disease, which is not obliterative bronchiolitis or exudative bronchiolitis. Now, hypersensitivity pneumonitis we consider an interstitial lung disease, but even here you will get features of airways disease. This is a patient who has subacute hypersensitivity pneumonitis, and you can see this widespread ground glass opacification, but if you look again hard enough, there will be these lobules which look like they are spared, but actually those are not spared lobules. Those are areas of small airways disease, and I happen to have a section from the same patient in which an expiratory scan was done, and you can see the preservation of that low attenuation, which causes that lobular kind of pattern. That's a telltale sign of hypersensitivity pneumonitis, the combination of ground glass opacification and these signs of airways disease. So in hypersensitivity pneumonitis, you also have features of small airways disease, and you speak to pathologists, they will say that is often a prominent feature in hypersensitivity pneumonitis. You can see it in the subacute phase, and you will also see it in the chronic phase. And these are just two patients with hypersensitive pneumonitis in chronic phase. Again, note these lobules, which look like they're spared, but they indicate the small airways component of HP. Sarcoid is not a disease we generally think of causing airway abnormality. Classically, you get granulomata, which are predisposed to the lymphatics, and here is a bronchovascular bundle, and you can see these conglomerate granulomata around the small airway. So it's not perhaps surprising when you know that at a pathological level that you will see features of small airways disease. This is a gross specimen, and this is what we're generally used to seeing, but however, if you look hard enough in patients with sarcoidosis, you will see features of small airways disease, and indeed there are patients with sarcoidosis who on their initial CT may only have features of small airways disease. So a pattern of small airways disease is entirely consistent with the diagnosis of sarcoidosis. To finish, this is a little bit of a rarity, but it's something that could be like a reputation-enhancing case. And let me just show you, because it's a little bit of an Aunt Minnie. If you ever see the combination of small airways disease together with multiple small nodules in the lungs, this happens to be a transplanted patient, so ignore the right lung, but that combination is something that you see in patients who have so-called microcarcinoid tumulates, as it was originally called, or diffuse idiopathic neuroendocrine cell hyperplasia. When you see that combination, say to your clinical colleague, aha, I think I've spotted a case of dip neck, and they will obviously fall off their chair, and your reputation will be made forever. Anyway, that's the kind of last case. What is it? Well, I've already said there are little carcinoid-like lesions around the small airways. These patients present with mild to sometimes very severe but irreversible airflow obstruction. The chest X-ray will show features consistent with small airways disease, but it's the HRCT on which you might be able to make your reputation. The combination of small airways disease features together with small nodules, think about neuroendocrine cell hyperplasia in the lungs. So ladies and gentlemen, that's been a very quick tour through the airways, but I hope I've shown you that diseases of the airways are incredibly common, particularly the small airways. The CT features are very varied, particularly when it comes to the small airways, but if you think about the two main categories, constrictive obliterative bronchiolitis, where you will see the indirect signs of airways disease, and exudative, you will have most bases covered in the diagnosis of small airways disease. A knowledge of pathology is always very important. Again, as you probably, those of you who are in the excellent session this morning with Jeff Galvin and Phil Boisel, that knowledge of pathology is crucially important to our radiological interpretation on CT. Thank you very much for your attention.